have patients who are in the hospital with other problems. You spend time in clinic seeing patients, and you also spend time in the cardiac catheterization lab where you're assisting with interventional procedures, putting in stents, things like that. And also electrophysiology. You rotate through doing pacemakers and ablations and things like that. So you see a little bit of everything. But out of all of those things, because the echocardiograms, nuclear stress testings, there's a lot to cover in 3 years. Something has to get shortchanged to get the basic working knowledge in each of those areas. And usually that ends up being lifestyle and prevention.
Mm-hmm. So after doing this cardiology, at what point did you become more of like, a couple of years ago, I started noticing that you're talking more about holistic approaches toward medications and prevention, and you were one of the first people in the area that were verbally like that. I saw so much content from you for your patients about how to prevent, and I wanted to like understand what led you to this transition in your career, because it kind of aligned with mine, and that's one of the reasons that I wanted to specifically talk to you.
Sorry about that. Yes, no, I would say the way that happened is I didn't have a sense of any of that when I was in my fellowship. At that point, all I knew is that I loved cardiology. I loved acute care, sick cardiology, but I also was always driven towards, attracted towards prevention. And I always thought about it. And, whenever I thought about exercise and things around lifestyle, they just seemed to me to be such potent pieces of the puzzle and things that were missing. But when I went out there into practice, at first it was sink or swim. I was in a very, very busy practice, not the one I'm in now, where you didn't have a lot of time to see patients, and a lot of patients are very sick. And I was just trying to learn how to really do that at a super high level. And I would say, after 2 years there, I realized I wanted to step back a little bit and be able to spend more time with patients and really try to get to the bottom of what was happening with them. Because what I was seeing in the very busy first practice I was in is that we would definitely see patients who needed a stent. They would come back to us. We would do a lot of high-level medication management, but inevitably we'd just see more of the same coming through. The same patient would come through, a year later, or I'd see people coming in who were having chest pain, who had 7 stents over the last, 10, 20 years. And I realized that it was not fundamentally changing their outlook. It was really just, putting a Band-Aid on. So I had that awareness, but it wasn't until I changed to my current practice where I had, a little bit of a different culture and more time to spend with patients. And that's when I started being able to really research. I said, well, what do we know about this? Why does exercise work? And I would start doing, in the time that I had on my own, I would start reading, what do we know about how exercise affects the body? Same thing with nutrition, really deep dive into, because especially just like many of your listeners probably, you can be so confused. I mean, until you really find a source of information that you trust and who can make sense out of everything out there, if you just pay attention to headlines that come across your email inbox, it sounds like eggs are both terrible for you and healthy for you. And, red meat causes cancer, but it doesn't cause cancer. And, all of these things took a lot of effort of sitting and trying to sift through them. Along the way, I also started to, have certain patients who I met and other providers that were in the more holistic field of also including, supplements. And I didn't know anything about that beforehand. And I always was open-minded. So I started to learn. And I've learned along the way that, if you spend time and, really research it, many of these things get a lot of hype and there's really nothing to them. And some of them really have good scientific evidence they can help. So over time, what happened is, as I started learning this stuff and talking to people, patients who were more interested in these approaches to medicine and to cardiology care started coming to see me. So it evolved in that process. It wasn't like I had one aha moment where, I was sick and I cured myself with some magical supplement. it was just along the way, a gradual realization that if I just do everything that all of the world experts who write the guidelines for doctors tell me to do, I will improve the situation for my patients, but I will not stop them from having more disease. I might delay it, but it's just not going to do that job. And really just branching out, learning what I could about other ways to influence it.
So then this new place that you're working, do you think that's you're the director for cardiac disease at Mount Sinai?
Yeah, so I wear a couple of hats. I mean, I have a very busy practice and I take care of a lot of patients with traditional disease, traditional risk factors, and who honestly will tell me they're not super motivated to make a lot of changes in their diet and their exercise, what have you. And I, use medications in those people, and we do a lot of that work. And I'm the director for all the cardiologists for Mount Sinai doctor practices in Westchester. So we have 3 practices, Scarsdale, Yonkers, and Pelham, and I'm the director for the cardiology across those. But within my practice, I have also developed a much more personalized approach, an approach that is, individualizing assessment of people's risk and trying to implement anything that I've learned along the way that seems to really add value. To knowing who's doing the right things and who's not, and how can we get them to do more. I would say that what's really moved the needle for me in the last couple of years is that I've met people, in various fields and with varying backgrounds, some of whom are MDs, some of whom are naturopaths, some of whom are chiropractors, some of whom are nutritionists, who are really top of their field and understand some of these elements very well. And, we've started collaborating more and more, and you just learn a lot from those people. So now I have a practice where I implement as many of these integrative modalities as possible. And my attitude is I try to do for every patient what I would do for myself if I had significant risk. And that includes whatever I think seems to have a likely chance of helping and a very, very low chance of harming. Mm-hmm. And that's everything, whether it's prescription medications, which it often is as a treatment plan, to lifestyle coaching, and in some cases, certain supplements and nutraceuticals.
That's so you do think that there are some supplements that you offer for heart health? Sure. I know I'm going to get into some of the questions that we had planned. I have, if you're okay with it, we have like a couple of slides that we can share the screen and open for you. Yeah. Have like some questions that we were getting, and there are some questions that are coming in from the audience. So if you're okay, we can just hit some of the questions and just give us like a quick roundup. I know that we are limited in time, but this was your first run with us, and if you enjoy it, then we would like to see more of you. So the first question, so this is your on Muggle Rounds, which is rounds that I have created for, these are medical information for non-medical people. So this is basically my patients, my clients, people who may be interested in learning more about cardiology, and we are basically trying to make some of this jargon understandable so people can follow it. So one of the things is that, what is coronary disease? This was like, how would you tell someone who, this was a question. And then I would like to move these questions. So I don't know if I can move them for you, or who's moving. Can I have the access to it? Who moves it? So and then what are the symptoms of coronary disease? And then another question that we show you. And maybe you can bunch these questions. And what are the risks of coronary artery disease? Like, what are the risks that what leads you to it? So what is it? What leads you to it? And how can we figure it out? Is it symptomatic? Or if you do not have any symptoms, how to figure it out? Like, what should a patient ask the doctor? Does everybody need a stress test, for instance?
Sure. So it's a lot of topics there, a lot of information. I'll try to simplify it and
You
keep
don't have
short.
to do all of them, just like whatever is easy.
Yeah, no, absolutely. When we talk about heart disease, it's a very, nebulous term. It includes a lot of things. When we talk about coronary artery disease, we're specifically talking about the arteries that feed the heart muscle, and developing plaque. Okay. Another word for plaque is formed from cholesterol. Another word for plaque in the artery walls is atherosclerosis. It used to be called arteriosclerosis many years ago. Hardening of the arteries, all of those things are synonyms for the same process when plaque builds up in the artery walls. So coronary artery disease can be thought of as a spectrum. So if you are somebody who does the type of testing that I do, which many cardiologists have been coming around to doing more and more, but it's not always offered, you can pick up atherosclerosis in the walls of the arteries before somebody can feel it, before it's obstructing flow or causing, God forbid, a heart attack. So that's, in traditional medicine, we still treat those people as if they don't have disease because we often don't know it's there if we don't look for it. But if you're aggressive about looking for it, then I consider that your arteries are diseased. Now, they're not at a point where they're causing you any symptom, but there's plaque sitting in the artery walls, and that's the beginning of the problem. Then you can develop gradual accumulation of plaque where it starts to encroach on the inside of the artery, right? If it's just in the wall of the artery, but the inside of the artery is wide open for blood flow, nobody's going to ever feel anything. And if it starts to encroach and impair blood flow so that when you're, walking or shoveling snow, you don't get enough blood flow for the heart muscle's needs under that exertion, you get chest pain or shortness of breath, you get symptoms. So that's called what we call stable coronary artery disease. We call it stable because the plaque is there, but it's not actively changing or clotting, and you feel symptoms if you get to a point of exertion that exceeds the amount of oxygen supply you get. The worst case scenario is unstable coronary disease. That's when somebody has a plaque sitting in the artery wall, and something changes with the biology of the plaque so that the plaque now is exposed to the inside of the artery, and certain things are exposed to the blood cells going by called platelets that make them clot. So that's how you get a heart attack. And you get a similar thing in the brain, by the way. The process is very similar. If you have a stroke, it's plaque in the artery wall, which suddenly something changed and caused the platelets to clot, and that's how you get a stroke. So the symptoms typically are going to be either exertional symptoms if you have stable disease. It can be chest pain. I know a lot of your audience is women. That's a very big area of confusion because a lot of women have heard that women are more likely to have atypical symptoms, and that's very true. Still, the most common symptom is chest pain, but people, men or women, can have shortness of breath, dizziness or palpitations when they're exerting themselves, sometimes even confusion or just generalized weakness. If you have a sudden heart attack, then it can be any of those things, as well as, feeling like you're going to pass out, profuse sweating, even vomiting. So that's what coronary disease is. And to prevent it, you really want to try to start as early as possible, ideally before plaque has even started to form, to do all of the things that can prevent plaque formation. So that gets into the risk.
Let me insert this one question that is still stuck. So you were mentioning right at the beginning that there is one test that we should do, which we are not even doing, to look for if you have the disease and you have no symptoms. So what is that test?
Right. So there's a few different things you can do. If somebody does not have any symptoms and it's appropriate to get an idea of what's going on with them, the most common test is called a coronary calcium scan. That's a very, very low dose CAT scan. So it has the benefit of being an extremely low dose with extremely low radiation. It's like having a few chest x-rays done. So it's extremely safe with almost zero risk. And because it's low dose, it's not going to give you pretty pictures of the artery walls and everything happening, but it's going to see from outside the heart if there's calcium anywhere along the arteries, because calcium is extremely bright and very easy to see on a CAT scan. And the reason that matters is just that it tells you there's plaque there. You're not going to get calcium in the wall of an artery unless there's been plaque there for some time.
Oh, really?
When plaque forms, it's originally all cholesterol, and over time, As it matures, it becomes calcified. I won't spend too much time on this point, but that's actually a good thing. That's not a dangerous thing. When the cholesterol in a plaque is exposed to the inside of the artery, that's when you have a heart attack. Calcium does not cause that reaction. So when we treat people aggressively who have plaque, one of the goals is we can never make it totally disappear. But if it all becomes replaced by calcium over time, we've converted them to a stable situation where that plaque will never kill them. Okay, so calcium is not dangerous, but it's easy to see on a low dose CAT scan. And so the coronary calcium scan is a very powerful predictor of someone's risk for heart attack or stroke in about over a 5 to 10 year period. It has limitations. It's not covered by all insurances, although it's not particularly expensive. It's usually a little over $100. For some people, in occasional cases, we can do what's called a CAT scan angiogram, a CT angiogram. That is a test that shows you exactly what's going on in the arteries, and it shows you all of the plaque, including if they have plaque that's all cholesterol and is a higher risk plaque that hasn't calcified yet.
So would you recommend these tests in younger people, or
so the
older people would probably have an abnormal scan here and there? No?
You know, basically the way I approach it is I recommend the tests when I think it's going to change what we do. So if somebody comes to see me who doesn't have a very concerning family history and their risk factors are pretty well controlled, if I can get them into an optimal exercise regimen and diet regimen, I don't need to know what that scan shows. But for many people, either one, they lack the motivation to get really on top of things, and they know how important exercise is, but something else is going to go by the wayside if they schedule exercise into their day every day, and they're having trouble making that, compromise. Or for some people, their cholesterol or blood pressure remains at a level that can promote coronary artery disease despite their best efforts. And now we have to decide, are you going to go on a medication or not? And even then, for some people, they say, absolutely. If the chances that over my lifetime, this medicine is much more likely to help me than hurt me, I'm going to take it. And in those cases, I work with them with meds. But for some people, they need to know more before they can make that decision. Also, as a doctor, sometimes, there's good blood pressure, there's very good blood pressure, and there's perfect, beautiful blood pressure. Where am I going to draw the line where I stop increasing medications? So their risk matters. And in those people, I do the tests. Basically, in answer to your question, I think doing a coronary calcium scan is very reasonable in every man over the age of 40 and every woman over the age of 50, because those are the ages where you start to see some of the people who are having disease at an early age are going to be positive. It's
so
very unlike
the disease. Then what next? Like, would you give like some kind of anti-cholesterol medication? And the reason I'm inserting this question in time for you to address is because we're getting some questions like, what medications do you recommend for high cholesterol? Do you recommend regular Lipitor or Crestor? Right. What makes you decide between Lipitor, Zocor, or Crestor? And also there was one question about apolipoprotein B. They're asking that, is there a test where we can figure out if there is like a good cholesterol or bad cholesterol, and how bad a bad cholesterol can be, and how can we find the really, really bad guys?
All right. So I actually don't think we can skip over any of those. So let's address all of them. First of all, you asked, what do you do if you find plaque? So I'll tell you what I do, but not every patient wants to go that far. And I meet people where they're at. I see my job as to do everything in my power and in the patient's power to maximize the chances that they're going to reach the age of 90 without any heart disease or strokes or other artery disease of the legs, aorta aneurysms. They're all related to atherosclerosis. I'm waiting and waiting for the beautiful test, which does not exist yet, where we will be able to do something on a person every year without high amounts of radiation, because we could do it now with CAT scans that are very sensitive, but they have too much radiation to repeat every year. And we can measure what exactly is happening with the atherosclerosis, and we have a quantitative number that we can get from the study And we know when you pass a certain number, that is the point where you're almost certainly going to have an event in your lifetime if we don't intervene. But we don't have that test. So short of that, the way I approach it is, the only person that I can say to, you seem to be at no risk of heart attack or stroke at the moment, is somebody who has had multiple tests looking at arteries and we see no plaque anywhere. Okay. Now, the ideal thing would be to be able to look at the arteries of the heart and the arteries of the brain, because that's where you're going to get a heart attack or stroke from. We don't have any imaging tests that can see the relatively small brain arteries clearly enough to know if they have plaque in their walls. So if I have done, let's say, a coronary calcium scan on a person and it's perfectly normal, and if I do, sorry, my screen is timing out. If I do a carotid artery ultrasound and it's totally normal, then I can tell that person, you seem to be at no risk. If you have plaque in one of those locations, that doesn't mean you're at high risk, but it's on the table for you. You are someone that could have this happen. And at that point, my approach is to work with the person to try to optimize every risk factor we can. Now, as I said, some people say, okay, I understand all of that, but I'd rather just lower my risk, but not take a statin drug to get my cholesterol perfect. And I say, okay, then let's optimize everything else. But my general approach is every risk factor should be optimized. Now, cholesterol, does it cause heart disease? Cholesterol is a very important risk factor, and it is critical to the formation of plaque, but it's not the whole story. And that's why if you spend time online Googling this, you will see all sorts of different opinions, some from people who don't understand it in detail, and some from people who do, and you'll see different things. Some studies show it's a weak association. Well, here's the story. You cannot get plaque unless cholesterol gets from your bloodstream into the wall of the artery. That is the first step. But that is not plaque at that point. That is a cholesterol-carrying particle, which is called an LDL particle. Just remember that name, an LDL particle. Each of them is carrying hundreds of cholesterol molecules. It gets stuck in your artery wall. If it just stays there and is untouched, you're not going to form plaque. But if it never got there in the first place, there would be no chance you're going to form plaque. So step one is the less LDL particles you have in your bloodstream, the less likely any of them are going to get stuck in your artery wall. But after that, there are subsequent steps that have to happen to form plaque. You have to first have a process called oxidation, okay? So oxidation is when any substance that has oxygen in it in a certain type of electrical state binds to another substance. It's when a green apple or a red apple turns brown after you slice it, or when iron rusts. In your artery wall, trapped LDL particles have cholesterol on them. The cholesterol can become oxidized, okay? So that's step two in the formation of plaque. First, it's an LDL particle gets stuck in the artery wall. Then the cholesterol gets oxidized. It undergoes a chemical reaction with a oxygen-carrying compound that we call a reactive oxygen species. Step three is that white blood cells of the immune system come and identify that as foreign and think they need to attack it to get rid of it the same way they would if you had a bacterial pneumonia invading your body. So the white blood cells gobble up a lot of oxidized cholesterol, and that is plaque. Plaque is when you have completely engorged white blood cells that have died and they're full of cholesterol, okay?
It's like a pimple inside the artery?
That's right. But the reason I use that framework is because when you think about stopping that process, using medicine to lower your cholesterol is a very important part, but it's only one part. If you are somebody who has a lot of oxidative stress with many of those reactive oxygen species floating around your body and your artery walls, you might form plaque even with relatively low levels of cholesterol, because anything that gets trapped there is going to get oxidized. If you are somebody with inflammation, an accelerated immune system that is hyperactive when it shouldn't be, you're going to have a lot more white blood cells in your artery wall looking to gobble things up, and you're going to form plaque. So we start by lowering cholesterol, and then we try to address oxidative stress and inflammation. All right. Lifestyle is extremely important for steps 2 and 3, but it does not lower cholesterol very much. Okay. I am sorry to burst people's bubble. That doesn't mean I don't try.
There's no amount of exercise that's going to fix your cholesterol.
So there are rare people that I see who have amazing responses to anything that gets them to lose weight. Their cholesterol goes down a lot when they lose weight and when they exercise, or when they make diet change, but it's rare. Now, that's not at the extremes. At the extreme, if somebody is eating a lot of processed red meat and a lot of processed heavy creams, ice cream, butter, cheese, and they cut those things out, you can see numbers come down nicely. But usually somebody who's eating decently well, doesn't eat tons of fast food, and just says, I'm going to stop putting cream in my coffee and I'm going to have, hamburgers once every 3 weeks instead of once a week, it doesn't do it. So, however, eating that way and exercising regularly is by far the most powerful way to improve steps 2 and 3, oxidative stress and inflammation. But to get your LDL particles down to a really low level that is associated with very low risks of heart disease, of coronary disease, requires medication for the vast majority of people. Now, I want to say one other thing. It is very important for people to understand that when you use statin medications, you lower LDL particles in the bloodstream, so you lower the likelihood of step 1 in the process happening. But those medicines have been proven that they reduce oxidation and inflammation in the body and in the artery walls. So a statin medication is potentially impacting all of the steps. It's doing step 1 more potently than exercise and diet, and it's doing step 2 and 3, oxidation and inflammation, less potently than exercise and diet. But together, you get a magnified potential.
Nice.
Statins do have well-documented side effects. It is extremely, extremely rare that they have very serious or dangerous side effects. There's a lot of talk about, people, online, people becoming disabled from statins. If you're seeing a cardiologist who listens to you when you talk and pays attention to what's going on and doesn't just, rush you through in 10 minutes, if you are having side effects, it is almost guaranteed it will be something that can be detected by a history, a conversation or blood work, and is almost always reversible. That being said, the most common side effects, which really can be impactful to a patient's health, is number 1, elevated blood sugar. People can develop prediabetes or diabetes as a side effect of statins, but you're going to know if that's happening. You don't need to live in fear. You'll see it on the blood work and it'll go away if you stop it or decrease the dose. And there are very, very, very rare cases where somebody notices their memory is worse. Okay, that has been seen, it's been reported, and we know it happens. The concern that statins cause dementia is not a real thing. And I can say that with confidence because many studies have now been done where they look at populations of people who got statins over long periods of time versus ones who didn't, and they don't see an increased risk of dementia. They've also done analyses in randomized trials of statin therapy. Those are going to be shorter periods of time. Typically, it's 2 years, 5 years, and they have not seen any increased risk of dementia.
Do you think just high cholesterol causes dementia?
So the high cholesterol can cause certain types of dementia because there's some dementia that's related to vascular disease of the small vessels in the artery. And in that case, any risk factors for artery disease like blood pressure, cholesterol, diabetes can cause it. But this issue has been dealt with pretty intensively, including doing completely accurate state-of-the-art testing on people receiving medications that lower cholesterol. And it's never been found that on average, there's a higher risk of dementia. Now, does that mean it's eliminated that completely? No, I'm open-minded. That's why I said at the beginning, if somebody tells me taking this natural supplement helps, I look for, what's the evidence? I won't say that it is 100% proven that no person will ever get dementia from a statin. I will say that if it's possible, it is so unlikely that we can't find that signal that I would always tell someone who's at higher risk, it's much more likely to save their life to take it than that it's going to harm them.
So which one, like, how would you decide?
Yeah.
Like somebody who says that, which should I take, Zocor or Lipitor or Crestor? And I'm like, whatever your insurance covers. I mean, that's how I do it. But I want to ask the cardiologist, like, is there a point where I should fight with the insurance and spend like an hour with insurance to get somebody a better drug? Is there a better drug?
Well, the nice thing now is that all of them are generic. So usually insurances are equally welcoming of all of them. My considerations are these. First of all, if you need a large amount of cholesterol lowering to get into a respectable range, you are usually only going to be able to achieve that with Lipitor or Crestor, atorvastatin or rosuvastatin. Those are the most potent at inhibiting the enzyme that leads to cholesterol production in the liver and therefore will reduce it when you take the medicine. My general preferred statin is Crestor, rosuvastatin, and there's a couple reasons for it. One is the one that I just said, because it's a lot more potent. Even if someone doesn't need that much lowering, if you take a very low dose, you'll often get a really good response. And the side effects of statins, both the blood sugar and diabetes side effect, as well as the muscle and joint pains that people can get, are always less common at lower doses. But the other thing, and this is really more hypothetical than anything else, studies have been done that have shown that rosuvastatin cannot cross the blood-brain barrier. Okay, so these medications get into our bloodstream after we swallow the pill, and then we want them to stay in the blood and do their work on the liver. We don't want them to get into the brain and reduce cholesterol there, because the very rare person who seems sensitive to these medicines and has memory issues, it might be that is working through a process where it decreases the cholesterol in the brain, and they're much more sensitive to that than other people. So I'd rather use a medicine that can't get there, we think, based on the pharmacologic studies, and therefore it kind of makes that risk much, much less likely.
Nice, nice. There is like also a question about the apolipoprotein. Sorry, I don't want to miss it.
No, that's very important, actually. It's just that it's really complicated without visuals.
Just make it so simple that even
I'm going to try to
5-year-olds can
simplify
understand.
it. The first thing to know, the bottom line to know, is that apolipoprotein B is a cholesterol measurement. It's giving you an idea of how much cholesterol is in your blood, and it is doing so in a more accurate way than your typical LDL cholesterol number. And therefore, studies have shown that it is better at predicting artery disease, heart attack, and stroke risk related to cholesterol than your LDL cholesterol. That's the bottom line. The reason for it is that, remember I said cholesterol is in your blood. The way it exists in the blood and the way it gets into your artery walls is it's carried by LDL particles. So each LDL particle is a complicated complex of proteins and cholesterol, and each of them has hundreds of cholesterol molecules, and they form this little ball, and that's one LDL particle. So you have tons and tons of these balls that are each carrying lots of cholesterol. And if you get plaque, it's because too many of these balls, these LDL particles, get into your artery wall. So ultimately, to know what your risk is, you want to know how many of these balls are in your bloodstream. The best way to measure that is this apolipoprotein B. There is one of those proteins on each LDL particle. And we have the technology now to measure that reproducibly and fairly easily in the blood. And the concentration of the number of those proteins means that's the concentration of LDL particles. It's complicated to explain, well, why can't I just look at my LDL cholesterol? That should tell me, because it's the LDL particles are carrying it. What I will just say is that the makeup of people's LDL particles, I told you they carry hundreds of cholesterol. Well, one person's might carry 200 and one person's might carry 800. In those cases, if you just spin the blood down and measure just the cholesterol content, you may have had more or less particles carrying the same total cargo in that drop of blood. And most people, it doesn't matter a lot, but for about 20% of people, it matters a lot. Your LDL cholesterol can be quite low, but you have many more particles that are carrying that cargo, and you would never know that you're higher risk unless you do that ApoB test. So yes, I suggest everyone ask for it. Insurance does not always cover it, but more and more are covering it.
Nice. There is another question also. Is there any specific diet that you would recommend when you tell somebody to decrease their diet? And like, for example, people do intermittent fasting, or if somebody should do vegetarianism, or somebody should do a keto. I sometimes feel that people who go on keto, I'm like, will all that protein impact the vascular system? And then there is one other question that I thought you may like, do you recommend any vitamins or nutrients because um, uh, for your patients? And then another one is that, is it true that an aspirin a day is good for the heart? And is now, because with the new latest research on aspirin, now do you think that everybody who's in their older years should be on some kind of a thinner product, or no, blood thinner, or no?
Okay, so if I'm really efficient with my words, I think I can answer all of those questions in the 10 minutes.
Before the end of your thing. I know we have like 10 minutes, so you like 1 minute per question.
But I love doing this, and I love reaching audiences who may not get this information elsewhere or may get less accurate versions of it. And I would be very happy to come back and do more.
Absolutely.
In terms of the diet, you always have to understand you don't have any study of any diet in the universe, with the exception of a healthy Mediterranean diet. You have no study that ever looked at people over long periods of time in a randomized scientific fashion and saw who had events and who didn't. All the information we have is epidemiological. It's what we call observational. It's asking people what they ate usually and seeing who's healthier and who's less healthy. First of all, that is notoriously inaccurate. There are just tons. Everyone forgets what they ate. You know, if I ask you how many times in the last 6 months do you eat oatmeal for breakfast, you're going to give a ballpark figure. And yes, these questionnaires are quote validated, but they are not accurate. And when you're being investigated as part of a trial, you also feel more motivated to both eat better as well as to make it sound better. So all of this research is very murky. We do know, I will also say this, even without knowing for sure what is their one best diet, you can try things in yourself and see what lowers my cholesterol best, what lowers my blood sugar less, what gets my stomach flatter, which is not just nice to look at, but also very healthy. So you often have to try it because it's not the same in everyone. The Mediterranean diet, the true Mediterranean diet, okay, which really limits flour and breads and pastas, even though in Italy they eat that, but in Crete, which is truly the Mediterranean diet, they have it, you know, sparingly in small amounts. And they have sourdough bread, which is very low glycemic index. You know, it's not our whole wheat ciabatta roll at Subway. That true Mediterranean diet does have a long study that showed it reduced the risk of strokes, more so than people who just got health advice. So you're talking about olive oil, you're talking about a lot of plant-based, you're talking about poultry and fish with rare red meat, not a lot of sugar and carbs, and not a lot of dairy. So that's always a diet that I would consider a good go-to baseline. But notice the thing that most people eat a lot of that I said is starch it, flour, okay? If you're eating a Mediterranean diet, you are not having a lot of bread and pasta or tacos or wraps. Now, every other, what's that?
You just canceled out my usual diet.
I'm so sorry to do that to you. Pretty much every other diet that has strong observational data to suggest it's healthy has that in common. You are not eating a lot of starchy carbs. You're not eating a lot of processed sugar, high fructose corn syrup. There's varying amounts of red meat and dairy among the different diets, okay? So when people go vegan or vegetarian, if they are doing the college vegetarian, you know, the college person who says, I don't want to kill animals, it's not ethical, but they go to town on pizza, you know, without pepperoni, their biomarkers of health do not improve. But if you're truly eating plant-based, non-processed foods, not having flour, which is a processed food, you're going to see a lot of these markers improve. I generally tell people, if you're talking about what diet is likely to keep my arteries healthy, it's a low processed food diet. You can eat more or less of fish, poultry, Red meat you can eat more or less of, but it shouldn't be a frequent adventure. But it's not processed from Wendy's or Applebee's. It's healthily cooked at home, and you're not eating a lot of starch and sugar. To lower cholesterol is a different story. That's very hard to do. Plant-based probably does it the best. Intermittent fasting does not lower it in most people, but it sometimes does, because some people are sensitive to weight loss. And the most effective tool for weight loss for most people is intermittent fasting. Generally, the same thing is true for blood pressure lowering. Eating an unprocessed food diet is likely to help, but the most magnitude of lowering you're usually going to see from people who go heavily plant-based and lose weight, which often requires intermittent fasting. For improving blood sugar, it's trickier because some people will lose muscle mass if they do intermittent fasting or if they do purely plant-based, because they're not getting enough protein for their body's needs to synthesize muscle. Protein is the amino acid building blocks for muscle. And if you become under-muscled, muscle is the main organ that regulates our blood sugar. Most people don't realize that. The pancreas makes insulin, but the way the insulin regulates blood sugar is by telling muscle to take it up out of the bloodstream. Mm-hmm. So that's where it's different. And that's why a keto diet, heavy in animal foods, often is wonderful for lowering blood sugar. But because it has a lot of saturated fat, you can see cholesterol go up a lot. So you can try it, but you just have to monitor it. I don't want to skip over aspirin. It's very important. Aspirin increases bleeding across the board, but it's low risk. It's about a 1% per year bleeding risk, and you almost never die from bleeding from aspirin. Almost never, but not never. But aspirin also prevents platelets from clotting. So the newsflash story that said the U.S. task force said no more aspirin for primary prevention, that's true across the board. But those studies that they analyzed have all looked at people the way I'm looking at you now. I see your face, I see your body weight, I know your blood pressure, I know your cholesterol, but I don't know your arteries. I don't know what's going on inside. That's actually a more common reason in my practice these days to do these tests like carotid artery ultrasounds or coronary calcium scans. It's not just about should you go on medicines to lower your cholesterol or blood pressure. If people have plaque there, and maybe if it's a tiny amount, I might not put them on aspirin, but if they have a good amount of plaque, I think they're much more likely to have aspirin save their life than take their life. And in those people where it's unclear what to do, those tests can be very helpful.
So if somebody wants to have a blood thinning product, some kind of a medication and has to be on it, should it be Eliquis or aspirin? What kind of thinner should you recommend on a long-term basis for someone?
So for purposes of preventing clotting in the arteries, aspirin is enough. Eliquis will do it more strongly, but all of these other things that are blood thinners, Eliquis, Xarelto, Coumadin, warfarin, they inhibit platelets some, but they do a lot more. And so the bleeding risk is always higher than with aspirin. Some studies don't show that. They show equal bleeding risk, but the majority of studies will show a greater bleeding risk with those medicines versus aspirin. So the mainstay for long-term use is aspirin, unless you have one of certain diagnoses that we know those other blood thinners are better for.
Dr. Gitik, one last question, which is coming out from TikTok right now. It is because I am live on there also, and we're live also on YouTube. However, there's one question that I wanted to ask, because many of our clients and followers are from outside of the country, and they do not have the American healthcare insurance systems. So for someone who wants to come and get some treatment or some of these tests, would you happen to have any idea like what a cardiac catheterization would cost in United States, or what like a calcium scan would cost if you're paying out of pocket for something like this?
So a coronary calcium scan out of pocket will vary from the lowest I've ever seen is $75 up to about $200. And they're usually between $100 and $150. If you wanted to know everything going on in your arteries, and you wanted to do the CT angiogram, so the non-invasive CAT scan that looks at your arteries, those are usually going to be $900, $1,000 in that ballpark, $1,200 maybe at the high end. And I do have patients who opt to pay out of pocket for it because in their case, it's going to be what they need to make their decision. So those are the basics. By the way, in the 1 minute remaining, I do want to say this question about nutrients and, or dietary supplements, we would have to come back to do it justice, but some very basic things for people to start reading about that have a lot of evidence. And it's not just fringe, even central, mainstream cardiology, they know that there's some evidence. It's just that some studies are conflicting. We don't have all of the evidence to recommend it routinely. Fish oil, okay, omega-3 fatty acid, getting it through eating healthy, healthy fish options 3 times a week, like salmon, great. But if you don't like fish or you can't afford healthier versions like, non-farmed salmon, fish oil pills offer a lot of potential benefits for cardiac, as well as for inflammation in general, which we didn't get to talk on, other than I mentioned in the
I
artery.
have to bring you back next before December, before Christmas.
We'll do it. But, inflammation is not only important in the artery walls, it probably plays a very big part in dementia. So if you're interested in avoiding dementia as well, fish oils can be very helpful. Curcumin is a big one people know. It's an ingredient found in the spice turmeric, has anti-inflammatory properties. There's not as much research studies showing it improves outcomes as with fish oils, but it can sometimes improve inflammation. And so it's reasonable to consider. Magnesium work is very well, has very strong evidence, both observational and some research, that it can help specifically with arrhythmias. So if you're somebody who gets palpitations, skipped heartbeats that annoy you, magnesium is a very good one to consider. And there are some other things like CoQ10 and magnesium that can help if you have congestive heart failure or at risk for it. And there's pretty strong evidence for CoQ10 in those cases as well.
Is there something that we have to be concerned about how to protect our heart from after we have gotten COVID? For example, a lot of people feel as if they have some weakness, and sometimes they wonder if it is the heart that's getting impacted as part of COVID.
Well, COVID basically has been documented to cause everything in every organ system in at least one person. It definitely has caused, there seems to be links to it causing a heart attack and, a plaque buildup in the arteries. The more common heart conditions that it causes include arrhythmias like atrial fibrillation, which can be diagnosed with heart monitors. And more rarely, but still more common than coronary artery disease, is weakening of the heart, okay, which usually would happen through myocarditis. And everyone's heard about myocarditis because we're documenting it closely, whether the vaccines cause it, which we know they can, and whether COVID can cause it, which we know it can. But that is a very difficult thing to check, because often you won't even see it on a standard office echo, an ultrasound, and you'll need an MRI. But if you're having new cardiac symptoms, palpitations, chest pain, shortness of breath, those are the things you want to get checked out.
Thank you so much. I know we are a few minutes over your hard stop, but there are just so many questions. We just have to stop at this time. I am so grateful that you took time out to talk to the people, and we're going to be propagating a lot of this information to as many people as we can. And I would be in touch with you to bring you on and get on your schedule again and give us some time, because I think a lot of people would learn so much from you.
I'd be happy.
I follow you on LinkedIn all the time.
I'd be happy to do it. And by the way, thank you for lighting a fire under me to make it happen, because we've been talking about it for a long time.
People can depend on me for that.
We'll do it again.
Thank you. Take care, guys. Thanks for watching.
Have a great night.
We'll have Dr. Giddick back soon. So keep posting your questions after these questions, and we'll bring him back when we have at least 50. Excellent. Take care, Dr. Giddick. Have a good one. Bye-bye. Bye-bye. Bye.